Good evening, everyone. I'm Dr. Maunika. I welcome you all on behalf of Shield Healthcare. And I welcome you back to Icons in Conversation with Dr. Ritu. And today our topic would be genitourinary fistula. And I would like to welcome our speaker, Dr. Fozia Chandio. She's an MBBS, FCPS Gynae Obstetrics, Fellowship in Urogynecology from Aga Khan University, Hospital, Karachi, Fellowship in Aesthetic Gynecology, America, Specialist in Female Urinary Pelvic Floor Disorders, Fecal Incontinence and Infertility. I welcome you, ma'am, and I welcome Dr. Ritu Santwani, ma'am. She's an MBBS, MD, FICOG, FIAOG, AMR-COG, obstetrician and gynecologist, IVF founder and CEO, founder and CEO 360 Degrees Healthcare Studio in Amdar Multi-Speciality Hospital, Pune, and infertility specialist, NUHS Singapore, co-founder, MAAM board member of SWWC. I welcome you, ma'am. I hand over the session to you.
Yeah. Thank you, Dr. Monica. A warm welcome to all of my dear friends who have joined all across the geography. A very good evening to all of you. Today, we are having a very special guest with us, my very, very dear friend, Dr. Fozia. Though me and Fozia never met physically, but virtually we are connected from long. And our wavelengths are so much matching. And as the years pass, as I'm getting more and more knowledge about the Fozia also, she is a dynamic lady with lot of interest in the urology, in urogynec. So always her posts are very motivating about the fistula, about the stress on continence. So I thought, why should not we take this topic only today? Because all of us are getting these kind of patients in our OPD. And last time also when the Fozia has come in my show, that show was highly appreciated by all, because one very important point for the Fozia I want to mention, because she always focus on the practical points, not the theoretical points. What in our daily day-to-day practice, what the problems we are getting, she always focus on that. And she gives her opinion according to that only. Meanwhile, I want to welcome some of the friends have joined from the Africa. Dr. Samuel has joined, a warm welcome. Dr. Mona has joined from the Kerio, and my lot of friends have joined from the India also. So before we start, these lovely red roses for you, my dear Fozia.
Oh, thank you so much, darling. Thank you so much, darling.
So I think we will start. Everybody is waiting to listen to you, dear.
Yes. Thank you so much, Dr. Ritu. It is always a pleasure to see you and to talk with you. And it is after, I think it's a long time, a year gone after our last conversation on urinary incontinence. So I think this topic which I selected to discuss is the continuation of that as well. So as a fistula surgeon in Pakistan, we have 9 fistula centers. We are working with the Fistula Foundation World. And so one of my center is connected with the Fistula Foundation World with the name of Fistula Center Larkana. As we are dealing as a developed countries, we are dealing with such a disastrous situation of obstetrical emergencies and the repeated surgeries, repeated C-sections. And with the C-section, the women who are ended up with the total abdominal hysterectomies, the abdominal cesarean hysterectomies, they are always having risk of the damage of the surrounding structures like the bladder, the gut, the ureter, and all that. So this disease is devastating. It is a social, and it is a what we can say, it is a dilemma for the lady. For 5-year-old boy or girl, they are not allowing to pee on every site. So they are supposed to be trained for peeing on the private site. So in that situation, the female who is dribbling the urine throughout the day with the smell of urine, nobody try to sit with her, and their lives become miserable. they get divorced from their families, they get separated, they mostly they sit in the part of corner of the house, and their husbands, they never touch them, even they cannot fund them to for eating something even. So Ritu, the fistula is very problematic for all of us, for especially, and now I'm seeing that there's two type of fistulas what we are facing, that is the obstetrical fistulas and the iatrogenic fistulas. The obstetric, after the delivery, the difficult delivery, so we put always blame on the dais, the traditional birth attendant, the persons who are the people who are not trained properly. So we doctors, we blame them, but now whom do we blame? Well, then in iatrogenic fistula, it is done by most of all of us. So in that situation, we doctors are on the red light now. So for our training, it is very important that we must see that fistula is made by all of us. So as an obstetrician, as an gynecologist, I'm worried about our younger consultant that they will face these previous surgeries and ended up with the bladder injuries, and at the end they develop fistula. So this is one of the critical situation over here, even in our part of the world, like Bangladesh, India, Pakistan, the Africa. What we are thinking that everybody that fistula is at in the Africa, ये वहाँ की बीमारी है. So in that situation, no, this is the disease of our part of the world as well.
Yes,
So
yes.
surgical training is very important. I think
So
it's a
before
day-to-day.
Fauziya, we will shift to fistula. As you have very rightly pointed out, yes, in India also the rural part, the lot of patients still are coming, lot of fistula. But as you clearly mentioned about the incontinence of the urine. So first I want, because as you are urogynec specialist, so I want first some highlights that how you treat the patients of the stress urinary incontinence, because lot of patients are coming to us in the postmenopausal age group also, that are laughing, sneezing or coughing. Sometimes they are getting a dribbling of urine or drops of urine. So let's start first from that. So we will take the advantage of your knowledge. So how you are proceeding with the stress incontinence patients? Yeah.
Yes, Dr. Ritu, the stress urinary incontinence is the aging process. So we have the muscles, we totally depend on our hormones, the estrogen and progesterone. So once we lost that estrogen and progesterone after the menopause or premature ovarian failure, in that situation, our ligaments, which totally depend on our hormones, they become weakened day by day. So there is two type of medications. The treatment, the one is with the Kegel exercises, with the sort of pelvic floor muscle exercises, and along with that medications. But the thing is that they only give the benefit of 40% of the patients. For example, if we ask the patient that do the exercise pelvic floor, squeeze it for 5 seconds, for do this 5 times a day. So what happened in that pubourethral ligament? It is a skeletal muscle. Okay, so what happened in skeletal muscle? If they do more exercises, so what happened? The skeletal muscle become weakened. It become what we can say tired. So in that situation, the condition become worse. So for the exercises, the patient compliance is very important. So the situation is that if aging person is non-compliant already, and one is asking for them that do the pelvic floor exercises, so they become irritated. So I'm not supposed to do that. So there is medical management as well. But Dr. Ritu, the main thing is that it is surgically corrected. Okay, in this surgically corrected, the one thing is very important, go for the urodynamic studies. And for example, in Pakistan, there is a lot of hospital, they lack that system, the urodynamic machines. There is no urodynamic machine in the most part of the world. So what happened, there is special training for the interpretation of the results for the correct stress, what we can say urodynamic stress urinary incontinence, means should be proved by something. Because most of the time what happened, the overactive bladder, the UTI, the weakness of the neurogenic bladder, all the system become mingled with the stress urinary incontinence. So it should be sorted out, differentiated from the neurogenic bladder as well. So if there is stress urinary incontinence, there is two type of procedures. The one with the synthetic material and one with the grafts by body grafts. Okay. So in that situation, what happened? The FDA approved FDA has banned on something like the meshes and all that because they have the complications. And that is called the tension-free vaginal taps, the mini slings, the operator slings. So there are the multiple surgeries offered for the patients. But in that situation, they have the problem of rejections, infection, proper learning curve that everybody cannot perform that surgery. So in that situation,
Sahiti, please mute everyone. Except the speaker, please mute everyone. Yeah.
Okay.
Yeah. Sorry for that, Fajia.
No. And another thing is they're doing the MM kits, no? Marshall MM kits, and there is a lot of surgeries. But the thing is that one should go for the urodynamics before embarking on the surgical procedures. They are invasive. And they should be done by the trained person who can properly do that procedure. And also for the postmenopausal women, for nowadays there is the sprays are there, the oral sprays for that contain some sort of placebo and some sort of medications that give the strength to the body, like that.
Yeah. So as we all know, yes, in the menopausal patients, yes, some benefit we are getting by the estrogen application also. So here we are getting these days now estrogen as a sprays also. So yes, so we are using in some patients that for the uroepithelium, and in some patients, as you told, the placebo therapy. Yes, so a lot of components are coming now these days. The soya products, glycerols, all these are coming in the ointment.
Yes, the supportive treatment.
Yeah. So how you find,
even as I have done the cosmetic gynecology.
Yeah, Fajia, how you find the results by these placebo therapies? You are finding some patients good results?
Yes, up to the 20%. If it is a urodynamically sound stress urinary incontinence, so it need, for example, in urodynamics, if the VLPP pressure is less than 90 or more than 100, so what happens? We give the treatment according to that. How that ligament sustain the pressure of the cuff, sustain the pressure of the body. Okay, so the treatment will be the worsen the condition, more towards the surgery. The lesser the condition, the more toward the conservative one. As in a cosmetic gynecologist, nowadays we are also offering the HIFU for that, the vaginal laser. And that is again promising, doing the constructions and all that. And even we have the Amsila chair. For example, patients who are not which are not non-compliant to the Kegel exercises or pelvic floor, so they just sit to that chair, and with the MRI resonant MRI contractions, they start with the pelvic exercises. So the things are very improving, but they are costly, and they need special setups for that as well.
Very true. Yeah, Dr. Rakia, please mute everyone. Otherwise, give me the host right. I will mute everyone. So, as you have clearly mentioned about this Amsila chair, yes. Of course, this Amsila chair is also used by some of the doctors, but the main problem is the same, is the cost. Cost is, that is very costly. So first to invest, because these kind of patients, especially those who are practicing in the peripheries, means for the fistula, I am telling. But incontinence patient, every one of us are seeing, whether of the low socioeconomic status or high socioeconomic status. Very correctly you have pointed out, yes, some patients are not ready for the Kegel exercise also. Some are having a difficulty for that. So yes, we can use this Amsila chair. And in some patients, the PRP is also showing the good results. But we have to explain the patient. We have to explain the patient that may or may not. So counseling is also very, very important.
Very important, yes.
Yeah. So you find any role of some drugs for the stress incontinence, or what you are using and how the results are coming?
We have in Pakistan, we have with the market name of Lita 2030. But the thing is that the drugs are not working with that. I work on the diagnosis, the proper diagnosis, because in aging women, what happens? There's most of the time neurogenic bowel, neurogenic bladder because of aging. So what happens? Their bladder become full and it जिसको कहते हैं झलक जाना ना. So in that situation, what happens? The full bladder, they most of the time spill the urine and they feel that this is the stress urinary incontinence. And what happened that all right. So once the diagnosis is very important, what the things are there, go for the PVR or the SAM KUB. If there's no urine and with a slight urine on the cuffing, there is urinary incontinence. So yes, it is the thing is that is urinary incontinence. But again, the urodynamics is very important. For me as a urogynecologist, I start all my surgeries with without with the urodynamics. If there is no urodynamics, you cannot diagnose it properly. Either it is a mixed one, it may be a mixed one as well. Either it is an overactive bladder, or either it is a stress urinary incontinence, or it might be a neurogenic bladder. So in the geriatric, I receive 3 parts of life of women: the pediatric population, the young women, the geriatric. So I'm sitting in a area where the female urologists are lacking. We don't have the one of the newly graduate. She started the journey as a female urologist, but as a urogynecologist, I receive all 3, and all 3 ages have the different causes of urinary incontinence. And the one of the difficult to treat is the geriatric one, because the constipation, it also fills the bladder, give the retentions, give the incomplete incontinence, sense of incomplete voiding, and they also ended up into stress urinary incontinence. They push and push to evacuate that gut, and what happened? They end up into the stress urinary incontinence. So drug have a very low role in that situation. I think that which is not corrected, that organ which is defected in somewhere, so it should be treated with a surgery. And as a surgeon, I love to do it.
Great, great, great. So now coming to the fistula. So friends, in between, if you are having any questions, please write in the chat box. So today we are having, I can say we are really lucky to have Dr. Fauzia with us. Who is ready to answer.
For me. It's honor for me always to talk with you.
My dear, thank you so much. I can say pleasure is mine whenever I interact with you.
Thank you so much, darling. Thank you so much. So in fistula, what we are, this is one of the, in my experience. So there are 2 types of incontinence in genitourinary fistulas. Is number 1 that they have continuous urinary incontinence. Okay, so they leak most of the time. And I have another type of patient is that they also go to the pee, they go bicturate bhi karte hain, and they also leak with the urinary incontinence. So what happened? The type of fistula is very important. It's an abnormal communication with the bladder and the vagina. So with the urethra, with the vagina, and even there is a communication with the uterus and the bladder. So there is multiple variations of the fistula. As a fistula surgeon, when I see the patient, every time it is different from the first one. So in that situation, patient may come to you that after the surgery or delivery, I feel urinary incontinence. It is a continuous urinary incontinence, not like a stress urinary incontinence that coughing, sneezing end up with the incontinence. So I think, I don't know about the India, but in Pakistan, we are facing more of the iatrogenic fistula, the surgeries, the fistulas after the surgeries. So in that situation, the bladder anatomy should be very elaborately read and understand by the gynecologist. As in a pelvic surgeon, we should know about the boundaries of our what we can say, the surgical area. It is very important to know about the bladder anatomy, the urethral anatomy, and anatomy of the gut as well. So I don't know about what is the is there the patient, are you receiving the patient of fistula over there in your clinic, or by a friend who is joining in our group?
I'm sorry. Sorry, your voice is breaking, Dr. Fauziya.
Okay, I think light is
Yeah,
gone.
yeah, light is
So,
gone. Yeah.
Actually, the thing is that I'm saying that is there is any one of our the participants they have ever seen the patient with the fistula?
I think Dr. Vijay Agarwal has joined. He's a urologist. Dr. Vijay, any opinion? So you can write in the chat box. Yes, now the electricity has come, I think. Yes.
Is there any question in that? Yeah.
Yeah. No, if he has seen any kind of the fistula, he can write in the chat box. No. Till now, we have not received anything. Yeah.
Okay. So in the fistula, the main important thing is that in fistula, it is very important that why it occurs and what time it occurs. If the bladder injury occurs during the surgery, try to stitch up or sort out.
I think Dr. Fauziya is disconnected. Yeah. Fauziya, you are muted. Fauziya, you are muted. Please unmute yourself.
It's all right now?
Yes.
Okay. So in fistula, if there's a bladder injury occurs during the surgery, so try to sort out the there and then. And if it is not, for example, the surgeons who are not clear about the previous surgeries and they are not knowing about proper the bladder, that what is the extent of the bladder. For example, in the rupture uterus, patient come into the emergency with a rupture uterus. The bladder is very adherent with that. The bladder may be ruptured with that. So as a gynecologist, I think every gynecologist should have a lion-like heart and sharp eyes like eagle, and and the soft hands like ladies. So the proper ladies, we gynecologists should know about how to handle the tissues, and they should not afraid of the tissues, afraid of the bladder. Like as a gynecologist, they said, "Oh my God, the bladder is out the way. Oh my God, call the surgeon." So till the surgeon or urologist reach to you, the time of anesthesia extends, the blood loss is extended, or आपके nerves, they become shattered at that time, and they say, oh my God, the bladder is gone. So bladder is very innocent organ. So it just required 2 layers stitching with the 2O, and the patient will be get rid of that fistula. But the fistula once happen, so it is very important to identify it, the type, how many fistulas are there, and number 2, the 3 is very important. Go for the cystoscopy to see the fistula tract, that how we can operate it. Either it is very close to the ureteric orifices, either it is close to the urethra, where it is. The site is very important. And another thing which I do, it's a classification of the fistulas. Like I'm not interested in the size, that it is 1.5, 2.5, less than 0. No, it is not matter for me, not matter for anybody. But what it matters, either you can operate it very easily from down or from the above, because the roots are from the vagina and from the abdomen. So what type of fistulas can do from the down, and what type of fistulas can do from the up? So in that situation, it is very clear for the fistula surgeon that one should go for the type of fistula. And I recommended all my audience that read the Waldegg classification. It is very important to go for before embarking on the surgery, go and read for the Waldegg classification, which is important for the fistula surgeon.
That's great. That's great. Thank you. Thank you, Dr. Fauziya. Dr. Fauziya, one thing I want to know, as you have very clearly tell us all the practical points, please share some tips and tricks what we have to follow post fistula repair. Because sometimes what happens, some doctors are sending the patient to the urogynec for the fistula repair. And later on, after the patient is discharged from the hospital after 2 days, 3 days, or maybe 7 days, later on follow up, they are coming to their routine gynaec. So what are the precautions they have to follow, or what are the guidance we have to give to the patient post-surgery?
Okay, Dr. Ritu, it is very good question, and I think one of my meeting, I just want to share an experience that after the one of my meeting, they say ask that we have 100% success result of fistula. So I said, oh my God, how come? So it's a miracle. It's a miracle. So they say, no, Dr. Saab, we have 100% success rate. I say, no, I don't know how that is 100% success rate, because in my patients, I become offended. Most of the time, I become offended in the patients ward that they just stood up. I have the pain over here. There is the spasm in the bladder. There is the urinary incontinence, there is the fever and all that. So the post-operative care is very success. It's a 98%, 85%, and you can go down till any level. So in that situation in post-operative care, once you operate the case, number one, the catheter there should be 3 Ds. 1 D is the patient should be dry.
Okay.
D2, there must be a proper drainage.
Okay.
Drainage means the catheter should be intact.
Yeah.
It shouldn't be coiled, kept to the side of the patient, shouldn't be kept on the side of patient. And if you are doing surgery near the urethra, so just attach the catheter loop with any plaster with the leg, because it should be a tension free. Otherwise, it will be pulled. So another thing is that there should be 3 D is the drink. Patient should completely hydrated every time to flush out all the blood, the residual from the bladder. And number 2 is, one of my paper is published that role of anticholinergics in post-operative cases of fistula. It's a Rawal Medical Journal of Pakistan. So, and I have presented in Nepal for the conference of ISOF. So in that paper, what we observed that there is a role of anticholinergics in post-operative care of fistula. Just give a post-operative anticholinergic to the patient, and what happens? It causes it stops the spasm of the bladder. So if there is no spasm, so what happens? No stretching of the stitches, so it will be relaxed, and the healing is very.
Thank you, Dr. Faucia. I think your net is unstable. Dr. Faucia, can you hear us?
You put a catheter for 2 weeks. So in that situation, the 2 weeks catheter, after that, check with the cystogram. If there is no leak, then remove the Foley's. Otherwise, don't embark to remove the Foley's, because what the work you have done, that is really a difficult work. So post-operative care is very important. What we say that is some of the time patients are already, they become very all right. But what happens, they feel that there is some sort of wetness in the vagina. There is a wetness in the vagina. So what happened, what we say, it is a mental incontinence, because they couldn't remember the situation. They couldn't forget that situation, in that sense that there is something which is still trickling down. So the counseling is very important. We sit with them, we talk with them, and we talk with them. So the rehabilitation is very important for the fistula patients. From a loomy face to the groom, they become shifted from that grief to a very happy faces. So post-operative care is very important. It is one of the very important step of surgery.
Thank you, Dr. Faucia, for sharing such important practical point, especially the 3 days. Very good. So we are getting some good comments. One is from Professor Vijay Agarwal. He is writing very interesting talk. And another is, thank you, Dr. Vijay, for joining with us. Another from Dr. Anita Madam. She's writing, we used to see a lot of obstetrical fistula earlier. Yes, very clear. Very true. Yeah, earlier. Yeah.
So in that situation, if they faces obstetrical fistulas in their area, so that is which part of the India?
She's
part of
from
the
Delhi.
India?
She's from Meerut and Delhi. But earlier,
If
when
they
the
face,
forceps, I think forceps deliveries at that time we are getting a lot of patients, or when, or sometimes at the time of the craniotomy also I have also seen actually, but yeah. Hi, Anita madam. Huh.
Hi. We used to get
hi,
bad
hi.
obstetric cases.
Huh.
I
Oh
still
my
remember
God.
a case in which there was no anterior vaginal wall, no posterior vaginal wall.
Oh,
Means
it's a complex
everything had
system.
become one track. So we were
Oh
really in
my God.
shock what to do. She went into anuria and all that. And we were not,
Oh.
well equipped also at that particular point of time. I'm talking about lot back. But in Delhi, we are not having that kind of problem.
Not.
Because obstetric care is good here in
Good.
capital
Now
city.
it is now it is trending. Its time has been changed because we have HR is more, the doctor has less force, and the people have very good access to the hospitals and the small other hospitals like
Absolutely.
NGOs. They also working on that.
And these days,
Absolutely.
due to the easy accessibility of the net, even as patient is coming
Yes,
from the
yes.
periphery, also they all are searching everything in the Google and then are coming. Yes, we don't want to
Yes,
wait.
Google.
Yes.
Yes.
And ma'am, we have now more
So-
than 80% institutional deliveries in India. So
Yes,
that
very good.
that is
Yeah.
the thing.
That-
So
Yeah.
we can avoid. So what is the condition in
So
Pakistan for you?
it's a women empowerment. It's a women empowerment now.
True,
Actually,
true.
and what about Pakistan, ma'am? What about Pakistan? What is your
Ma'am, I'm not ma'am.
Dr.
I'm
Fauziya?
not ma'am. I'm a junior doctor. And another thing, in Pakistan, we are facing iatrogenic fistula. There is a lot of iatrogenic fistulas over here. Almost we are receiving 60 to 70% of iatrogenic fistulas. So we are not now facing this bad wave of the surgical skills. So we are now working on our postgraduate. They should learn how to save the bladder, how to save the gut, how to save the rectum. So we are working on it. So inshallah, everything will be all right. But in Pakistan, yes, we are still facing the obstetrical fistulas. Even we are facing the coital fistulas, after the consensual marriage, the rectovaginal fistulas after the consensual marriage. So see,
we have
trends are
also
changing
seen,
throughout.
Defornitial fistulas I have seen, coital.
Oh, so
Sometimes,
there is one of the.
Then it becomes a challenge for the surgeon. Yeah.
They become the challenge for the surgeon. Actually, the fistula is challenge for the surgeon in that way. We are managing those cases which are already defaulted. So they are not straightforward cases. They are very difficult to treat.
Yeah. Thank you, Dr. Fauziya, and thank
Dr.
you, Anita
Ritu,
madam too.
my dear friend Professor Balkis Shabir is with us, and she is Dean Medicine in Fatma Jinnah, Lahore, and she's my best friend, and she's also
I am
listening
too.
my
I am
talk.
too your best friend. Yeah, welcome.
Thank you so much. Good for you. Yes, you are.
Welcome, Professor Bilkis. Welcome. So nice to have you with us.
Thank you so much. Thank you.
Hi, madam. Kaisi hain?
Position, but it's a great gathering and बिल्कुल ठीक ठाक और I know Dr. Fauziya has a medical education he is and how interested especially she is in making an impact on the society and how much she is contributing to the society in way of improving lives of people. So this is something which I think
Hi, madam. Thank you so much, madam.
Cannot be described in words what she does for women. Words.
Thank you
so
madam,
much. Thank you so much, madam.
Thank you for joining with us. So, I think we are not having
any question, Dr. Ritu?
No, we are not having any questions.
So there is another form of fistula is ureteric fistula.
Yeah.
So that ureteric fistula is one of the another dilemma in which the female loses their kidneys and even. During the surgery, if you go more lateral to the uterine, just ureter run under the bridge. So it's bridge of the uterine artery. So in that situation, what happened if we go very deep while taking the uterine artery pedicle during the hysterectomy? So what happened? Try to be more towards the uterus, not towards the lateral side. If you go more lateral, so what happened in that situation? Most of the time, they got the ureter as well. So the ureter is the main source of the drainage of the urine from kidney to down to the bladder. So if they caught it, so what happened? If it takes about 6 to 8 hours, the kidney start dysfunctioning. So in this situation, patient if come late, so they lost the kidney in the ureteric fistulas as well. So what happened? We just do the surgery abdominal, and we reimplant the ureter in that situation if patient come early. So see, it is again a reconstructive surgery. It requires more skills, more trainings, and but it is very essential to know about the proper course of the ureter for all gynecologists and for the women, for the lady doctors who are performing the surgeries. And for example, the morbidly adherent placenta, Dr. Ritu, is one of the another dilemma what we are facing, and that is with the previous surgeries we are facing that disease more and more. So in morbidly adherent placenta, if it is epercarita, so what happened? The vessels go inside the bladder. So if we are not knowing about the bladder, so what happened? Most of the time, they bleed, and bleed. They cannot control it. So again, in our I'm belongs to the College of Physicians and Surgeons, Pakistan. So we started now different type of exam procedure for the gynecologists that they know each and everything about how to do the surgeries. And they shift from the general examination type of exam to OSCE methods. So what happened? That extended talks. In the extended talks, what happened? They have one-to-one gathering and with the candidates, and they know they try to figure out how, either they know about the proper surgical steps or not. So yes, we are now working on it, and inshallah, Pakistan will be fistula free as we are celebrating Fistula World Day on 23 May. So our motto is that by the 32, so we at least try to figure down the things which are for up to the 72% till 32%, inshallah.
Very good, very good.
And
of course, yeah.
And,
Yes,
and another thing that Ritu, which I want to add that investigation of the fistula is very important. How to investigate the fistula.
I was going to ask that only, and you. I was going to ask that only.
So it's yes. Yeah. What the gynecologists we are mostly doing, we are doing the examination with the biomanual examination. But in a fistula, there is examination that is EWA, and the proper is the cystoscopy, either rigid or flexible. In the rigid cystoscope or flexible, we are just going to visualize all the bladder thoroughly and the association of fistula with the ureteric orifices. If we operate the fistula and ureters are very close at the margins of the fistula corner, so what happened? We can cut up the ureter as well. So what happened in that situation? It is one of the difficult things which for the fistula surgeon to localize the ureter first. And it is very important that you should localize the ureteric orifice and then put the ureteric stents over there and save the ureters. You can put the DJ over there, the DJ stent for the safety of the ureter because you can feel, palpate that either they are on the stitch or not. So the cystoscopy is very important for mapping of the fistula. Urinary culture, urine culture is very important. For the ureteric fistulas, IVU or CT urogram is very important in that situation, and 3D CT is very important. So whatever you require, but the simple thing is that as an urogynecologist, I think the one cystoscopy is the preliminary investigation for the fistula patients. Previously, we are used to say that 3 swab tests. We put the catheter inside, put the 3 gauze pieces in the vagina, and see either they give the blue dye and check either the gauze is blue or not. So that was just like a layman, what we can say. So now it is obsolete.
Yes,
so
now
most
no
of
one is
most
doing,
of it's absolute now. We are not performing it, even not in the Ladakh. It's a very small city, but we are trying to give our patients the more and more advanced things, the more and more good things for them. So apart from all fitness services, the cystoscopy is very important for the fistula surgeon. I think every gynecologist must know how to do it.
Yeah. Thank you.
And
thank you.
One of my paper.
Yeah.
One of my paper on the PRP.
Okay. Okay. Yeah.
On PRP, there was one of my paper I presented in Oxford, London, in St. Hilda College, that role of PRP in fistulas. So because the healing process is very important in that situation. So what I have done, I have put the 3 patients on a clinical trial with all consent that we will go for the PRP of the fistula after repairing it, to give strength to them, to give more collagen, and to give the more tissue support to them. So in that situation, 2 of my patients were successful, the one was not successful. So we stopped the trial in that sense that yes, the surgical technique is very important for the repair, for successful repair. How you handle the tissues, how you handle the fibrous tissues, how you give the incision, and what is the type of fistula, either it is close to the cervix, close to the urethra, lateral. It is a variation. It's for me now, it's like my love to perform the fistula surgeries.
That's great. That's great. So, Dr. Fauji, I request you, once you're doing the cystoscopy, please put 1 or 2 videos how to do, or next time I will invite you for the talk. You can show us some videos for that, how it is useful for the gynecologist, how the gynecologist can do that cystoscopy. Because this program is seen from the beginners up to the very experienced doctors also. So that will be beneficial for everyone. Hello, Dr. Vijay. Welcome.
I will love to. I will love to.
Good evening.
I will put both the flexible. Hi.
Yeah. Good evening.
Hi, madam.
Hi, good evening.
Greetings. We have some role of a laparoscopic repair of fistula. Like high fistulas now can be repaired transperitoneally, and we can go directly near the scar, open up the scar, and suture both the layers after dissection. And also interposition of some tissue, like omentum is the preferred. Or we
if
can
you're doing
use
abdomen,
appendicular epibloy of the colon or some peritoneal flap transabdominally. For very complex fistulas, we can go combined repair, like per abdominal plus per vaginal. And the third thing is we can use some flaps in the vaginal repair, like Marcius flap, or where tissues are deficient, we can use some.
Yes. We are also putting the Marcius.
Yes. So, and it's a very big topic, because as you go along, more and more complex cases come to you.
Yes.
So,
yes, thank you so much. It's a very
of the things you have covered very nicely.
Thank you.
Thank you so much. Thank you so much.
Thank you.
So thank you, dear Fauji, for sharing your knowledge with us. And
thank you so much, Annie. Thank you so much.
Before we wind up, friends, I want to show you one small video.
Mobile.
Friends, please block your time for this Sunday, 1 PM Indian Standard Time. It is not very good. This is my this is the academic marathon in which we are having the 14 national and international speakers. And the registration is totally free. and they all are coming, and they are So link I will be posting tomorrow on all the social media. This is totally free. All are welcome to join. This is academic marathon from 1 p.m. to 8:30 p.m. on Sunday, 18th June. So please block your time and you can gain a lot of knowledge by joining this program. So thank you once again, dear Fauziya, for joining with us. It's always a pleasure to having you with us. Thank you, dear. Thank you.